My name is Myrna Durrami, and I am a field marketing specialist for Boston Scientific, and I'll be the person moderating this webinar for you this evening. This evening, you're going to have a presentation by the GastroOffice, and they will be speaking about incontinence, specifically fecal incontinence, and the common symptoms that patients experience, as well as the treatment options that may help you to regain that bowel control. So just please be advised that these slides contain safety information about the products you will learn about today. As with any medical procedures, there are some risks. So please visit either the website of the doctors, gastrooffice.com, or the Axonics website for more information. And remember to bring all of your important questions with you when you make an appointment with the physician. I'm going to pass the mic over to the doctors because they will be speaking about fecal incontinence and the common symptoms that patients experience, as well as the treatment options that may help you regain bowel control.
Thank you so much, Myrna. That was a great intro. I'm Dr. Modi. I'm going to have Dr. Akudi introduce himself a little bit later as well, but just a touch about our practice. We're an independent practice here in Hilliard, Ohio, so we service the entire Columbus area. Dr. Akudi opened the practice back in 2018. I joined him in 2021, and the beauty of our practice is that we strive to give excellent care, and there's no red tape, so there's no big hospital administration. It's very one-on-one personalized medicine, and we handle, a wide array of, topics. The biggest topic today we're talking about is fecal incontinence, and I want to, jump right into that. So I think when I hear patients talk about fecal incontinence, these are some of the things that kind of come to the foreground, is saying, I constantly have to stop at rest stops on road trips. I have to worry about where I'm going to eat, or missing, the best part of a movie when we go out. I always have to look for the closest restroom. And so it can really impact the quality of life. And also, I think most importantly, is it's embarrassing to talk about with your family and friends. But your condition is not a normal part of getting older or caused by something that you did. And so it's really important for us to shed light on this and talk about this condition, so we can get you back to living your best life. And I think it goes without saying, but your quality of life isn't just going out to see friends and family. There's physical component to this. There's a social component too, is maybe having to cancel lunch or dinner plans because you are nervous about, let's say, having an accident, or worrying about urgency symptoms, or having issues in terms of work, or even with your partner as well. Those are all things that we need to think about too. And so it's not easy to bring up these topics with your physician. And so those are things that we really are trying to kind of break the stigma of here at GastroOffice. All right, so as I mentioned, you're not alone. Believe it or not, 1 in 12 adults suffer from some sort of fecal incontinence. That's almost 19 million people in the United States. And so for us, I think the most exciting thing from our standpoint is that there are treatments to get you back your life. And most importantly, we're one of the only GI physician groups in the city of Columbus that are offering to, kind of work with you and get these things figured out. And so I really want to explain how this condition comes about and what our process is here at GastroOffice. And Dr. Arpudi is going to help work on understanding what are some therapy options as well. So what exactly is normal bowel function, right? And I think that's really important to understand. Your rectum is the last 6 inches of your colon. And so that's where it can hold a lot of poop. And it basically stretches until it tells the brain that, hey, I think we need to go use the restroom. And so that's where you get that signal from, that you need to go use the restroom. And then it's actually a pretty complex system process. When the brain gets the signal, it tells you to go use the restroom. You have to relax your pelvic floor muscles. You have to elongate your rectum and kind of push out while your anal canal kind of relaxes as well. And so there's a lot of muscle function there that's really important, a lot of nerve signals that need to communicate. So what exactly is incontinence, right? I think it's important to think about it as a spectrum. Fecal incontinence is the uncontrolled loss of stools. So it can be solid, liquid, mucus. I think the first stage of that is urgency. Like, oh my God, got to run to the bathroom, right? Sudden urge to pass stool. And then sometimes in those moments where you're not able to get to the bathroom, we call that urgency fecal incontinence. And that's where you're at dinner, you can't find the restroom, or someone's in the stall and you have to wait, and you have an accident, right? And so that's urgency fecal incontinence. And then the last part of this is passive fecal incontinence. And so that's when you start leaking stool with activity or without even awareness. Let's say you're in the middle of the night and you wake up and your underwear is soiled, and you don't even realize that you're emptying, your bowels. So when you think of it as a spectrum, a lot of people struggle with urgency, and we want to prevent you from having to get to incontinence levels of either urgency or passive, leakage of stools. As we mentioned, the good news is there are treatments to help you regain control of your bowels. And it's really important to kind of go about this in a systematic process. And that's something we follow here at GastroOffice, is making sure we're doing right by you. It's not just, we got to, do a procedure, fix you. It's like doing the right things to understand what's happening. And so, in terms of how we should think about this, the first thing is that even before you get to the doctor, this is something you're dealing with every day. And one of the things that we always encourage all of our patients to do is make a dietary log. Like, is it related to any specific food groups, such as dairy, gluten? Is it sugary sweets or sodas that you're having that you notice that you have urgency or, accidents with? The other thing that's really important is actually even making a bowel log, because a lot of times incontinence may not actually be diarrhea related. It could be constipation, where you're not pooping for a couple of days and then, kind of everything comes out all at once, right? So overflow. So it's really important to understand where your symptoms are, what are your triggers, and then what have you tried so far? So that's the best way to think about going into an appointment with any specialist, especially with us. It's having an organized thoughts really helps us get to the bottom of things. The first thing we do, believe it or not, it's not doing a colonoscopy. It's not checking your pelvic floor muscles. It's just working on understanding what are your triggers. What have you tried? Is there any dietary modifications we can make? My biggest go-to for anyone who's having diarrhea or incontinence is actually bulking with fiber. So fiber is around 25 to 30 grams of fiber a day. With the normal American diet, I think majority of us are not hitting those numbers. And so just adding 2 tablespoons of fiber, in water and mixing. I like the powder version compared to, tablets or gummies. I think it gets absorbed a little better. And if you can do 2 tablespoons, about 6 grams, even at nighttime, we recommend. So that way, when you wake up, you're kind of primed to have a more formed bowel movement. And so it's about 25% of the fiber intake that you need for the day. So that's number one. Let's try some fiber. I think most patients, by the time they get to a GI doctor, they have tried Imodium or some anti-diarrheal medication, but that's something, certainly to think about as well. And then from a GI standpoint, usually we do 2 things. So the first one is, if you are of age and after 75, it's not always required, but a colonoscopy can be a really important tool to make sure it's not an obstructive process, or if there's inflammation, God forbid a mass, things like that, where you really don't want to miss something, obvious or treatable. So colonoscopy can, I think, fit as a rule out test to make sure that other things that could cause incontinence are not causing it. The second part, and I think where it's a lot is missed here, is that understanding your pelvic floor muscles. And so, as I mentioned, the rectum is the last 6 inches of your colon, and your anal canal is the exit point of the colon as well. And so we actually do something called anorectal manometry, where we have you come to the office. There's no sedation, no prep, no driver. We lay you on your side, and we place a catheter in your bottom. And that catheter is a third of your pinky size, so it's very small. We have you do things like squeezes and pushes, and we can actually measure the sphincter strength as well as your pushing strength as well from your rectum and your anal canal to see how your pelvic floor muscles are functioning. And if we see weakness in the sphincter, one of the most important things to do first is to work with you doing something called biofeedback. So we have a nurse practitioner who will work with you 4 to 5 sessions, about 30 minutes to 60 minutes, depending on your needs. And we will do squeezing, kind of pushing if needed, and see if we can regain some of that strength. And so when you think about initial treatment, it's more of what are the low-hanging fruit that we can rule out with a colonoscopy, as well as to actually assess your muscle function. So, that's a lot of information, but I think if you break it down into what to do before you come to the doctor, it's to know what you've tried, what food triggers you possibly may have noticed or have. And then the last thing is even making a log or a poop log of your symptoms as well. And so with that, I'm going to hand it over to Dr. Raipudi so he can actually talk about some of the advanced therapies that are present. And what we're so excited about to talk to you about today is how can we get you back to yourself if you have gone through some of these things and not been successful.
Hi everyone, I'm Dr. Krishna Raipudi. I'm a gastroenterologist and obesity medicine physician. As Dr. Modi mentioned, I've been in various locations, did a lot of academic, private, big groups, small groups, startup practice and everything before 2018. And then I started my practice in 2018, and it's been busy so far. And we bumped into this fecal incontinence issue like 5-6 years ago. And this is where I got interested, because a lot of people, like as Dr. Modi alluded to, do not bring it up with their doctor. And before this therapy was introduced into our practice, it was very hard to treat these patients because they come with a problem and there's not much solution. It was mostly those conservative measures like Dr. Modi was mentioning. So then this therapy was introduced. So this is transanal irrigation, but this is a kind of an old method, or not utilized as much, and is very cumbersome to do. But if you flush out the lower part of the bowel with water, it softens the stool and causes the stool to move towards the rectum to get evacuated. But this is to be done on a regular basis, and it'll prevent. One of the things I tell people in my practice is, if you do have this problem and we're still figuring out or need to get fixed, all you have to do is, at least to maintain in the short term, do empty your bowels more frequently. Like, let's say you're going to go on a trip, whether you feel like it or not, just go to the bathroom, empty yourself out before you go to the mall. So there's not much remaining, so you don't have to search for a bathroom. And the other thing is, Dr. Modi was mentioning, is also the Imodium pills we use after the workup is done. That could be used preemptively to at least not search for a bathroom. And this is another method of evacuating the bowels. And this is where surgical sphincter repair, yes, is an advanced therapy for people who have tears in the bottom. And it's very common with females. The whole issue is more common in females in general because of the makeup of the pelvic floor. Females have two areas of weakness in the bottom, the front and the back, right? So you need to protect both areas, and males have one area in the back where the anus is located. So the sphincters are relatively well maintained. And also the female goes through a process of childbirth. If you do a vaginal delivery, that also causes trauma to the sphincters in the bottom, which may cause tears, and usually they're repaired, but some people develop bad tears. I had a patient who was like 34 years old. This was back in 2018 or 2019. And she had a very difficult vaginal delivery, and she developed a deep tear all the way to the anus. And she, from then on, could not literally hold any stool. And she was only 34 years old. And she used to have accidents very frequently. And there wasn't much we could help with at that time, because this therapy wasn't available at that time, or if it was not a method that could be used easily. So the This is where the endoscopic ultrasound for the anal sphincter comes in. So some people, if we suspect that they have trauma to the bottom where they tore the sphincters, then we usually look at it with an ultrasound, which is available at our surgery center. And we put the scope inside and we look at the sphincters to see if there's any continuity issues when you look around the sphincter. There's an internal anal sphincter and external anal sphincter. You have two sphincters, and the internal sphincter maintains your continence when you're not focusing. So let's say I'm talking right now. I'm not leaking out stool. It's because my internal sphincter is holding it. That means that my body has an autonomous mechanism that will hold my stool if I'm not focusing on it. So that is what the internal sphincter does. The external sphincter, which is outside, is voluntary control. So let's say I go to the mall and I have an urge to pass stool, but I don't find the bathroom. Then the external sphincter comes into play. It holds the stool inside, and so you can wait until you get to the bathroom. But as we get older, generally there is weakness in both the sphincters, but that doesn't mean everyone leaks out stool. So getting older and leaking out stool is not a normal thing. You probably are on, then the sphincters have gotten too weak. And the biggest part is the external sphincter, which cannot hold, and that's when you develop the fecal incontinence. And in addition, there's damage to the internal sphincter too over time, which will contribute. And so those two sphincters play a different role, and they both are affected and cause symptoms differently. So then if we assess those sphincters with the procedure called endoscopic ultrasound, that means you're able to look through the layers of the gut wall and diagnose if there's any discontinuation of the sphincter. Then that's a tear. And in those cases, we refer you to the colorectal surgeon so they can fix that sphincter. Otherwise, doing other things may not fix it. Because there's a mechanical problem, which means needs a mechanical solution, which means fixing the sphincter. So this lady I told you about, the 34-year-old, did not have a sphincter issue at that time when I looked at it with ultrasound. Her sphincters were intact. They were healed after the scarring happened, after the scarring that developed with the tear and suture repair and suture with repair. So, but the lady still had incontinence. But the therapy I'm going to talk about next would have helped, and we really tried to reach her. I think a few times, probably her address changed or something. We could not get in touch with her. I'm still looking for her because we have this new treatment available. But that is a perfect example of a patient where it could have helped her lifelong because she's young and needs to have a life, and you can't have a life, as Dr. Modi described in the beginning, if you're constantly having a fear of leaking, smell, and all the stuff that comes with it. So this is the surgery for sphincter repair, and the therapy we're talking about is sacral neuromodulation. As you know, most muscles in the body work because there's nerve supply that goes to them. And the nerves are just like wires, electric wires that take signal from the brain and send it to the muscle. So the same way, your brain sends a signal and the nerves deliver it to the muscles. So we're focusing on the muscle. Okay, it might be getting weak. It is torn. Okay, we looked at all that. That's all fine. So then what else could be a problem? It could be the connections, like the wires are not working. So then what you could do is this is a simple procedure where you can do a test in office, and it takes less than half an hour. And we've done a bunch of these procedures between me and Dr. Modi. We've been doing a bunch of these because we're trying to raise awareness around this condition, and we've gotten excellent results. So you just pass a little wire on either side in the lower back with local anesthesia, so it won't hurt. I mean, you'll have some pain, but not terrible pain. We numb up that area, and we pass these hair-thin leads into the back, and they stay in there for 5 days. And you come back after 5 days, and we remove them. So what happens when you insert those leads? So they send signals that gently stimulate those nerves that control the bladder and the bowel. And I think we did not mention it so far, but this therapy actually was originally designed for people with urinary incontinence, where people are leaking out urine. So they tried this, and then they noticed that people who also had stool leakage had improvement. So then they said, okay, fine, this area seems to be helping both the front and the back, which is the urine and the stool. And so we should probably use it for fecal incontinence. And that's how the therapy was designed for fecal leakage. And some patients have both. If let's say this is a perfect typical example is like a 75-year-old female who has like urinary incontinence. And over the years, like at 70, she probably was just leaking urine. And at 75, 76, she starts to leak out stool as well. So that's how this progresses. Because if you're not addressing it, it could result in both urinary and fecal incontinence. So now, once you stimulate these nerves, you're just causing the muscle to contract, and that keeps the tone intact, and it keeps the urine inside and stool inside. And it generally works for both. Even if you do for one condition, it works for the other. But we are specialists in gastroenterology, so we encounter patients with fecal incontinence who are leaking out stools. So this is where we discussed how these wires are inserted into this lower back or upper buttock area. And only problem with that thing is once I put those leads in, or you cannot shower for 5 days. So you'll have to just clean yourself, but that's the only drawback because we don't want the leads to get wet or get infected. Infection is rare. I had one patient who got like a mild pus in that area. We gave some antibiotic, it got cured. And if you're on blood thinners, before we do this procedure, we ask you to hold for a particular duration before the procedure, which could be anywhere from 2 days to 5 days, depending on the type of blood thinner you're taking. And otherwise, the only other issue is you'll be lying on your belly. If you're not someone who lays on their belly, that might be like a thing. You might have to lay there for like 30, 45 minutes. And usually the procedure is quick. You'll be aware of the procedure. You'll be awake. And it takes under 30 minutes, max of 45 minutes. And once you insert the leads in the back, which are like two very thin leads, like wires into the back, and we tape it up, you go home with the recorder outside on the back, taped to the back. And then the company actually can monitor what you're doing, and also you'll be filling out a diary with your symptoms during those 5 days. Like how many times did I leak out stool or did I leak out urine? All that stuff will be recorded. So and the company will be remotely monitoring how much current you're using. And that's where this comes in. See, the device looks like this. This is like the permanent device. There are two varieties. And earlier, there used to be therapies for this, but they consisted of placing a device, and that the charge used to run out like every 2 years or so. So you had to go in, do a minor surgery, take it out, and put a new one in, and that's how it used to go on. And doing repeat surgeries could also cause scarring in those areas. Then sometimes you might have to change the site, etc. So that was obviated when these people came out with the longer lasting devices, where usually this is a condition you see in older age, like usually 65 plus. And if you do have this problem, you put these things in and they last usually like 15 to 20 years. And there are two types of devices. That finer discussions we can have towards the end when you're ready to choose with the surgeon. So our role is primarily like diagnosing it, then getting to do a trial and deciding if you really are benefiting from this kind of thing. And before you come to this step, as Dr. Modi said, we try to rule out other things. And then, okay, this is your problem now. So let's address it, do a trial. come back after 5 days. Then we look at the whole diary and then decide if this thing is working for you or not. And you can increase the current or decrease it. And this is the device, the green one you see on the screen is like a remote that comes with it. You increase the current, decrease the current. So that'll increase the amount of strength you need in the bottom, and that can all be adjusted up or down. That gives you 5 days to test it. If you feel like it's working, then we ask you a few questions, then quantify how much you're improving. If it really works for you, then we suggest, okay, then go ahead and, as I showed in the previous picture, see this on the left side or right side, that little device in towards the far left. That is what is implanted under the buttock in a surgery, and it's the size of a quarter, and the battery lasts a long time. And that is done through a minor surgery. It's 45 minutes, and it's done by a urologist or some colorectal surgeons do it. And we refer you to them, and they're usually pretty good at getting you in quickly and getting this done. So patients ask all the time about implants and if they're MRI compatible. Looks like they're both compatible with the latest type of MRI scanners and the old type MRI scanners, so you don't need to worry about it. And 94% said they're satisfied. The 93% said they would want to go do it again. And this is a real examples of patients talking and how it helped them. So I think overall there's a huge potential for change, and we being a smaller practice, a private practice, I'm not worried about. We are not worried about like, oh, what is a volume procedure or what would bring us more revenue, etc. We are trying to focus on things that make a big difference. And when it works, it'll work out on every level because patient satisfaction, helping the patient is our priority. And so we really look for things that make a big impact, and we're trying to focus on those. So this is what I can tell you. And been doing it for a while, and Dr. Modi had great success. Patients are happy, and I think it's something I don't hesitate in promoting.
I believe this brings us to the end of the webinar. Thank you to you both for your time this evening. Thank you everyone for joining us. We hope that you found this presentation beneficial. And again, if you have any questions or you would like to schedule an appointment, please be sure to utilize the number that's on the screen at the slide on the presentation here, or visit their website, GastroOffice.com, to get more information. Thank you both this evening for taking out some time to share your expertise. We hope that everyone enjoys their rest of their evening. Thank you.
Awesome. Great job. Thank you.
Thank you so much. Bye.